No more questions. We'll go to the next session. Thank you, Sandeep, for a very illustrative description of the new guidelines. So next we have with us Dr. Anil Kumar, who is going to talk about an important topic as far as cardiology is concerned, how we should escape from heart disease. Very, very important. And we have Dr. Anil Kumar, who has an illustrious career in the past years. He did his MBBS and MD from Jipma Pondicherry and took his DM from GB Pant Hospital, Delhi. He is a member of the Royal College of Physicians, Royal College of the American College of Cardiology, and at the moment he is working in Aster as a lead consultant in cardiology. Over to Dr. Anil Kumar.
Thank you. Good evening, one and all. How to escape from heart disease? A very relevant topic because today morning itself, the Manorama, when I opened up, the ministers issued a statement that 25% of deaths in Kerala is due to heart disease. And prior to the COVID, it was around 2 lakh deaths. Now, every year, there are 3 lakh deaths happening in Kerala. And of this, 25% is due to cardiovascular disease. Even if it's not 25%, definitely it's the number one killer in Kerala. And even Keralites who have migrated to outside the world, I have worked in Dubai, even in outside, you find that heart disease is single most important killer. So how to escape? I purposely misspelled it. I was calling it a mnemonic when Dr. Sujit corrected me and told me it is a acronym. Yeah, okay. So when we talk about lifestyle diseases, that is the discussion that happens. What are the lifestyle diseases that we are dealing with? Heart disease is definitely due to all these lifestyle diseases. And I'm talking to a group of very senior physicians and physicians who know all about it. So it generally is a walkthrough through all these slides and focusing on the important updates that have happened. Often the question is, how does stress kill us? This is the normal pattern of any man, woman or anyone else. Starts with the alarm bell, waking up, goes all the way around, and even post-COVID and online working, you continue working at night also and again walk. So it is the stress that is going on and on. How does stress influence coronary risk factors? Often the individual is under great pressure to outperform himself. So the blood pressure goes up, the sugar goes up. And you've all seen this cartoon. And that prompted Salim Yusuf in 2001, one of the great cardiologists, to mention that both these phenomena, obesity and hypertension, is something which has happened in the last 100 years. And what is the Kerala paradox? Very high incidence of lifestyle diseases despite 100% literacy. Isn't it something paradoxical? You know everything, but you don't know anything. Diabetes is 20% in our population, high blood pressure 42%, cholesterol is more than 272%, 25% of men continue to smoke, obesity is 14%, and physical inactivity, more than 40% are inactive. And the sad thing is, 1 in 5 Indians will develop diabetes, and 1 in 5 diabetic is an Indian. And we have the unenvious degree of being the diabetic capital of the world. And if you ask me, why is it such a high incidence of coronary artery disease? It's a double epidemic of hypertension and high blood sugar, which is contributing to coronary artery disease. Significant change in physical activity, lower physical activity levels. Our elder generation was always active. Now our activity is limited to our twiddling our fingers on the mobile most often. Non-adherence to medications for lifestyle disease. That's what literacy has got us. We know the side effects of the disease, what happens in 1 out of 100 as against the 99% benefit. And add to it Dr. Google and WhatsApp University. You are as old as you feel, but if your arteries are as bad, you cannot call yourself. I would say you are as old as your arteries are. If the atheromas are all over your place, in the coronaries, in the aorta, some of the arteries look like this even when you are 35 or 40. And so WHO says the number one leading cause is that, but the number of heart attacks are just the tip of the iceberg. Many more waiting to happen. And you have to understand that billions are at risk of undetected cardiovascular disease. So I would say the modern man is inadvertently achieving considerable success in just eradicating his own species. We as physicians have to reverse this trend. And it's physicians and not cardiologists. So I'm very happy to talk to the API group of Ernakulam today and just illustrate some of the factors which cause this high incidence of coronary artery disease. We all know about the metabolic syndrome, and any three of these would qualify as metabolic syndrome. And so obesity is in the limelight. I'm sure many of you have heard about the recent medications which are available for obesity. What is epigenetics? Epigenetics is how your environment and your behavior can change how your genes work. You put a 35-year-old Malayali into the Gulf atmosphere. All of them have coronary artery disease at the age of 35 to 40, 45. I come back to Kerala, you don't see so much of young coronary artery disease. So the genes are affected by the way the environment is, the stressors, and you change a person's environment, the genes acts even worse. So this is the new concept of epigenetics, how the environment affects the genes that you carry. Already you have a high incidence of coronary artery disease, and this, all the metabolism changes, and you end up having coronary artery disease and any other disease which is affected by this environment. And now the new concept is cardiovascular kidney metabolic syndrome. We cardiologists, we used to talk about this alone. Now we know it's a common factor, cardiovascular kidney metabolic syndrome. You can also add liver to that. Now we have what is called the metabolic associated steatohepatitis. So cardiorenal to cardiovascular kidney and metabolic syndromes, this itself can account for 29% of the total death in USA. That's what came up in 2025 in the European Heart Journal. So there are various stages. I don't intend going through this. We had a symposium recently in Ernakulam on cardiovascular kidney metabolic syndrome involving the nephrologists, the cardiologists, and the endocrinologists. And this is what I talked about, the metabolic associated fatty liver disease. What we used to call as NASH is now called as metabolic associated fatty liver disease. And even this is associated with coronary artery disease syndromes. So you always have to quantify the risk of heart disease. There are many predictors available. The PREVENT one is the latest one, how to assess for cardiovascular disease risk. It's always now scores. You can't just say somebody is at high risk. You have to quantify that for him. The PREVENT equation is available online, where the age, sex, the blood pressure, cholesterol, diabetes, tobacco use, all of them are used. And we can quantify the risk to mild, moderate or severe. And I generally use the Q-Risk-3 score. It's very easy. With the patient in front of you, you can use this score and you can calculate the risk of a heart attack or a stroke. And I calculated this for a diabetic patient, and even the ethnicity comes into here. You can use the Indian ethnicity, and I quantified this patient's score as 28%, which becomes very high risk. What is the importance? We'll just come to it about. So an ounce of prevention is worth a pound of cure, and he who cures a disease may be the skillfulest. So he that prevents it is the safest. You can do any number of interventions. You can treat everybody with medicines, but if you can prevent it, that is the best physician. So here is my escape from heart disease. If you can go through each of the letters of this escape, it is an easy way to teach even the youngsters. Even I would want this to be taught even in the schools, so that they can teach their parents and prevent heart disease. Escape, the E stands for eat healthy, smoking cessation, sugar control, cholesterol management, aspirin, now only for select few, I'll tell you about that in primary prevention, pressure control, and exercise regularly. This was somewhere in the midnight of 2012 that I came up when the American Heart Association had come up with ABC for heart disease prevention. I thought that was pretty inadequate. A for aspirin, B for blood pressure control, and C for cholesterol management. But this is still to hit prime time. I hope to make it more popular in the years to come. So this is my escape from heart disease. I'll quickly take you through a few relevant points of each of this. Ready to stop anytime when we are running late. So let's look at competence of eat healthy. Why is an interventional cardiologist talking about this? Has he stopped doing interventions, you might think. But it's our job, each of us, to prevent heart disease in this generation and even the future generations. So these are the types of food which is in the market these days. You always have the person asking for decaffeinated, no sugar coffee with a triple hamburger. So that's what's happening. You are focusing on the wrong things. The Kerala meal is no better. 75% of our food is carbohydrates. We need to reverse that. And this is the most popular breakfast meal that's happening these days. You're all aware about that. And the biryanis and the kudimantis, I don't need to explain about this. But how to prevent heart disease? It's by eating more fruits and vegetables. And Mediterranean lifestyle dietary pattern is, you're all aware about it, where it's moderate in total fat. You don't need to go zero in fat. In fact, when you're told go low on your diet, you cut off the fats, you cut off the proteins in your diet, you end up with a high carbohydrate diet. That is the wrong concept, and that's what brought the cholesterol controversy. I will come to that. But Mediterranean type dietary pattern is full of fruits and vegetables, and less than 25% will be carbohydrates. The dietary approach to stopping hypertension, when you can have low sugar, low salt diet and have a healthy diet and prevent hypertension. These are all known. And avoid less salt, avoid processed food. These are the ways to go ahead to prevent heart disease. And WHO says less than 5 grams of salt per day or 2 grams of sodium per day is what is recommended. And this is what the world should adopt to prevent hypertension and heart disease. If I don't talk about keto diet, there will be discussions coming up here. This is reducing carbohydrate to less than 50 grams, and 70 to 80% comes from fat. But I don't think that is working good. In the short term, it is good. It can cause weight loss, blood sugar and blood pressure controls. But after 1 year, there has been no benefits in major trials. In fact, it can be dangerous for heart disease patients. After an MI, the next thing the patient asks me is, can I go on a keto diet? Even Harvard has published that keto diet in heart patients can lead to rapid weight reductions and can even lead to sudden cardiac deaths. So I wouldn't recommend keto diet in heart patients. Even intermittent fasting has its problem. I would say that take diet in moderation, have a good breakfast, have a smaller lunch and the least carbohydrate for dinner. That is the way to prevent heart disease. People who followed a pattern of eating all their food across less than 8 hours per day had a 91% higher risk of death due to cardiovascular. I know some of our doctors here also are practicing intermittent fasting, but I would advise that the evidence is not there for the long term. So look at this healthy eating plate. This is what we should all practice. Whole grains, carbohydrates less than 25%, good amount of vegetables and fruits occupying 50%, and make sure you get your 1 gram protein per kg body weight to make sure that you don't become thin, lean and weak. You don't need to cut down on your proteins. You can have fats up to 10% of your diet, but I would advise that your carbohydrate should be cut down rather than just cutting fats in your diet. And this is one question which will come up. In 2025, no cardiologist will recommend alcohol for heart health. Let us be very clear about it. If you are taking alcohol, it should be at a very low dose, because you know that higher alcohol levels cause atrial fibrillation, the holiday heart syndrome, heart failures, and you always recommend make sure that you recommend safely. They'll always say the doctor advised you can take alcohol. That is not an advice that we give in 2025. Smoking cessation, we all know about it, and everybody is trying to cut down on smoking. But you have to realize that smoking, even without cholesterol deposition, can cause heart attacks. This is a clot which I removed. You remember Sandeep talking to you about thrombectomy? This was an artery full of clots. This may look very small, but you have to remember that the coronary artery is only 3 millimeter. This clot is enough to clog your left anterior descending artery and cause sudden cardiac death. So it is thrombus which happens in smokers rather than coronary artery disease due to atherosclerosis. And if you stop smoking also, it takes 50% of the risk only comes down in 1 year, whereas it takes up to 15 years for a non-smoker to reduce to non-smoker level. So quit smoking, better not to start smoking at all. But then there are patients who resist and may still continue smoking, but you still have to treat them. Sugar control, I won't be teaching too much to the physicians about the importance of diabetes, but remember that it's a heart disease equivalent, and very good guidelines have come for management of cardiovascular disease in patients with diabetes. This is a 2023 ESC guideline. So atherothrombosis is very common in the diabetic patient. Now you know that if you prescribe a cardiovascular patient a diabetic medicine, it better be something with cardiovascular disease protection. And with that in mind, now we have the SGLT2 and the GLP-1 and the inhibitors, which are the most beneficial in heart disease. And now you'll soon hear that they're very useful. SGLT2, we have already established it in heart failure, the benefits, and semaglutide is going to be used in diastolic heart failure, and maybe more and more evidence is going to come. So I would not go through these flow charts, but this is the current recommendation of how to treat coronary artery disease with GLP-1, SGLT2, and these are the two medications that are going to be used more and more in cardiovascular disease. And target less than 7 with a long life expectancy for all cardiovascular disease patients. But if you have a shorter life expectancy, you might go up to 8.5. So this is the target which you are going to tell for primary prevention as well as secondary prevention. The LDL cholesterol levels will be lower, but HbA1c less than 7, BP less than 130/80, and LDL less than 100 is what for primary prevention of heart disease. When we come to cholesterol control, you have to remember that 200 is not a normal cholesterol value. It's an average of the urban population. If you look at the hunter-gatherer population, the cholesterol was only 100 to 150. And newborns have an LDL of only 30 to 70. So what we need, LDL maybe less than 70. Above 70, the atherosclerosis can happen. Especially in our ethnicity, I would say everybody should keep LDL below 100 at least, as we start growing older and older. And this was the cholesterol controversy I was talking to. Only 20% of the blood cholesterol comes from fat in the diet. 80% is synthesized by the liver from carbohydrates. So you have to cut your carbohydrates to cut your cholesterol. It is not fat alone. This was all the Google messages and the WhatsApp messages that said cholesterol is not important. You stop your fats in the diet, that doesn't help. It's the carbohydrate which has to be lowered. This just to show you the scientific basis. Lower is better. The lower the LDL, the better the less the cardiovascular events and longer the longevity. So there is no confusion that cholesterol has to be lowered. There are still non-believers among the physician group who do not take statins, but I think we have all enough scientific data, and lipid management is very important. LDL below 130 for everyone, 100 for diabetics, less than 55 as Sandeep pointed out for patients with heart disease, post-angioplasty and bypass, and less than 35 itself has been recommended for patients with recurrent events. If you have a CABG, a bypass, or an angioplasty, recurrent events, it's even worth getting it to less than 35. Triglyceride as a target, we don't focus so much. Less than 150 is good enough. So if you look at the high risk I told you about, it's the same thing being told again. Now, coming to aspirin in heart disease prevention. We all know a few years back, all physicians above 40 were taking aspirin to prevent heart disease. Evidence is now against that. Not at all for primary prevention. Only in secondary prevention has it been totally been recommended, or primary prevention with a very high risk. That's what I was talking. If there's more than 20% chance of a heart disease, a smoker who has quit smoking but is a diabetic, hypertensive, obese, you might give an aspirin. But otherwise, it's only in secondary prevention. And so all with established heart disease, after angioplasty and stenting, after bypass surgery, and people at high risk. What is high risk? I showed you the Q risk score where you can calculate the risk, and if it's more than 20%, you can give aspirin for primary prevention. Otherwise, routine aspirin is not recommended for preventing heart disease. It's more useful to have a statin instead. A 5 mg rosuvastatin may do more benefit than taking an aspirin every day. Pressure control, I have a little bit more on BP control, but I will not go through the current guidelines. But the sad thing is the triple paradox of hypertension. Easy to diagnose, but remains undetected. Undiagnosed in 30%. Easy to treat, but untreated in 40%. And even with effective treatments, it is still uncontrolled in 66%. So always the question, I am asymptomatic, why should I lower my blood pressure? It's a stroke, heart attacks, heart failure, and kidney failure by 50%. This is what you have to tell your patients. You may be asymptomatic, but if your BP is 160, 100, you have the risk of stroke, heart attacks, heart failure, and kidney failure. So if you control both blood pressure and lipids, ideally, you can stop up to 50% of heart attacks in the society. So dual control of blood pressure and lipids. Add to that, if you can control the diabetes, I'm sure we can achieve 70 to 80% disease prevention. So this was the ESC Congress where they came up with the latest guidelines on blood pressure control, and I was lucky to be there in the crowd to listen to the 2024 ESC guidelines for the management of elevated blood pressure and hypertension. And they've redefined BP as hypertension is more than 140/90. And elevated BP is 120 to 140/90. Non-elevated BP is less than 120/70. So it's become simple quite now. More than 140/90 is hypertension, and less than 120/70 is normal. So that is the ESC 2024 guidelines. And I won't go into details, but remember that ambulatory BP is very much important to control, to evaluate at times when you have office BP very high. The drugs, I'm not going to go too much into detail, but we know the drugs which are going to control blood pressure. I will just skip this hypertension part in the interest of time. But just remember that BP normal is 120/70 and hypertension is 140/90. We had 5 stages of hypertension. I remember JNC 6 when we had to memorize. So this is what we need to talk about. And all diabetics should have a BP of less than 130/80. Exercise and heart disease. So this is in 1953, the Lancet published an article when they realized that bus drivers were at a much higher risk of cardiac events than their conductors. Obviously, the sedentary drivers had more heart disease than the conductors who were moving up and down. So that was the first evidence of physical activity, inactivity being linked to heart disease. And it can be as bad as smoking. Sitting is the new smoking, in fact. Sitting reduces, physical activity increases the HDL, decreases the cholesterol, and it's the opposite for sedentary activity. So it's all important that we keep moving, and there are benefits of beyond heart disease lowering as well for exercise. WHO recommends at least for age more than 18 years, around 150 minutes of moderate intensity exercise per week, of which 75 can be vigorous intensity and aerobic activity should be required. A simple isometric exercise can also be added on, but aerobic exercises are required for at least in bouts of 10 minutes duration. What is moderate intensity physical activity? Just for the men in the crowd, helping with household and domestic chores also can be included as moderate intensity physical activity. And vigorous involves running, brisk walking, cycling, badminton, the very infamous badminton. I suggest that anybody starting an exercise program after 40 years of age in our population should undergo a treadmill test before they go in for vigorous intensity physical activity to prevent such unexpected deaths. I talked about the metabolic associated fatty liver disease. This is also the part of the same conundrum of metabolic diseases, and they were treating with lifestyle intervention, pharmacological interventions, and bariatric surgery. But now the new drugs coming in, I'm sure bariatric surgery is going to go out of the window with semaglutide and other drugs coming in a big way. So the obesity revolution comes to cardiology, and cardiologists have to be taking on these drugs also. I'm also involved in a trial of semaglutide in diastolic heart failure in obese non-diabetic patients. So we are also going to be using these drugs more often for cardiovascular indications. So we can have national and global strategies to reduce heart disease. 50% can be reduced by simple national efforts, but no one is ready to take these efforts. That's the problem. WHO wanted to reduce heart disease by 25% by the year 2025. We are in 2025. Nothing much has happened. Heart disease is still on the rise. UK reduced salt content. Mauritius switched cooking oil from palm oil to soya bean oil. Korea has worked the traditional diet, and Japan reduced salt intake. So these are measures which we can achieve on a national level. Even in the US, food is medicine strategy is coming up in a big way. Most of the foods have to have labels of the salt, the calories, and making people more conscious of taking food as medicine rather than more medicines than food. So when to start cardiovascular disease prevention? It's never too early, never too late. When in 35 years of age, I was walking around the campus in JIPMER, one person came and asked me, "Doctor, nam heart disease aaye on." It was as if exercise should be started only after heart disease. And you should try to control all components. If perfect control of one factor is not possible, total risk can be reduced by controlling the other factors. If diabetes control is difficult, control the blood pressure, control the cholesterol, keep LDL at the lowest. So it's up to you to lower your risk of heart disease and stroke. And I don't want to say, physician, heal thyself. Many people have still not controlled in our physician community itself. You should know your numbers, and you should convince all your people, all your patients and family members to know your BP, cholesterol and sugar levels. And use this escape formula, and maybe we can teach it to the society at large and prevent heart disease. Thank you very much. This is our the 360-degree heart care at Aster City, and we had a new block just started recently. So it's been a good 10-year journey in Cochin. I came in 2014 not knowing anybody in Cochin. Now I'm happy to be working at Aster City and be involved in the activities in Ernakulam. Thank you.
Very interesting and practical aspects. These should be the way of talking instead of going into too much complex. Everything in moderation, as he says. Physician, heal thyself. As he rightly pointed, most of us are not bothered about hypertension, diabetes, and other things, except giving advices to other people.
Exactly.
And the hypertension, as he said, is very, very important. 120/70. I still feel that should be implemented. Most of the youngsters have got, which I examined, has got blood pressure of more than 150, 90 and other things, but they refuse to accept the fact and stop taking antihypertensives. So very practical advices, Dr. Anil. Thank you very much for being with us. Any questions from the side? I think this topic questions should come from you.
Either it's too clear or nothing is clear.
And one
But it's
aspect
simple,
about
it's not
exercise,
difficult.
I should say, I am a sportsman having been there for 40 years, but most of us are misusing exercises. This is very important. We see now 50-year-old and 60-year-old playing tennis for 2 hours and other things at 7:30 p.m. to 8 p.m., but they refuse to have a cholesterol tablet.
Exactly.
So exercise is being misused. You know, as he rightly said, I am an eyewitness to 3 deaths while exercising. My own colleague, one while playing, shuttle, one playing football. And so my advice, as he advises, is let doctors don't exercise as YouTube and other things says. And rightly he said, after 40 years, have a treadmill test before going to exercise. So any more advices, recommendations and comments on this?
Your all experience, I would like to share here some of your experiences on cardiovascular disease prevention. Yes.
You can take any food you like. No need to reduce fat, etc. What is your opinion?
No, there are very effective medicines available for cholesterol management. But if you have to take medications without controlling your diet and without doing exercise, it will be at a high level. So a high dose statin always has its some effects. You all must, otherwise people would ask you. High dose statins can increase blood sugar. The borderline fasting blood sugars or borderline pre-diabetics can become diabetics. But if you do exercise, food, the medications have to be less. Then there is this, maybe you're talking about the new injectables which are available. We can get down LDL to as low as 8, 9 and all. I've seen patients coming with LDL of 8, 9. You don't need the diet or exercise to control that, but that comes at a huge cost. And not everybody needs that. I would say exercise in moderation, food in moderation, and then medications. I have had marathon runners come and fall. I have done angioplasty for marathon runners. So exercise alone is not enough. Food alone is not enough, but medications also. And everything, I think there is a moderation in everything. Even recently, we have a study which says extreme exercise is associated with higher incidence of sudden death. And it's not with those with hypertrophic cardiac myopathy alone. Even the normal people can have arrhythmias and other things coming up which may be undetected. So diet control has to be there. I mean, we have to have moderation, but doesn't mean that you take away all the good things in life. You can have your once a week dinner outside with whatever you want to eat, but the 5-6 days you control and then have a break for a day. Even diabetics have a drug holiday. You can have that ice creams once in a while, maybe. Sugar-free ice cream. Yes, very true. Yeah.
And
No,
it's
now
not
it's
very
very
uncommon.
nice to put Instagram that I've done the marathon, but do your checkup and then run the marathon. You can, and after training, not on the day of the marathon that you decide to run 5 kilometers.
And you mentioned WHO says roughly 150 minutes per week the
Per
exercise.
week. Yeah.
Now, what is the maximum we can do? What's the ideal level of exercise? There is no mention.
No, minimum required is 150. One that is 30 minutes of exercise per day, and hypertensive it's advised that every day you should exercise. Now again, if you are cardiovascularly fit, you can train yourself for anything, but it should be with proper training and after a proper checkup.
So is more the better?
No, more is not better, definitely. But minimum level should be maintained. That also is there.
As far as statins are concerned, we got rosuvastatin and atorvastatin, which are
Correct.
commonly being used.
Yeah.
And some recent studies suggest that pre-diabetics we must avoid rosuvastatin, and we should preferably go for atorvastatin.
Okay.
But in all other situations, you can use either of them.
But a lower dose at rosuvastatin also does not push up sugars. When you try 40 milligram, you see I am seeing the fasting sugars go up. But that has also been actually in this group. We should know that when I am trying for a target of 55, the HbA1c goes up to 6.3, 6.4 and all. But
true.
now again, the moderation has come in. LDL 70 or less is enough, though 55 is better. So we have to balance it all out. Again, if you give 250 patients statin, around 10 of them might become diabetic in 5 years' time. But if you don't give 250, the same group don't give, there is the statistics, 25 of them will develop an acute coronary event. So it's a risk versus benefit that you have to understand. And statins, if you don't tolerate, there is ezetimibe, bempedoic acid, Sandeep was pointing out about inclisiran once in 6 months. The cost will come down. Currently, it's 1.2 lakhs every 6 months. But I'm sure the cost will come down as usage increases.
So we had an interesting session. My last comment is please start using staircases rather than lifts, even for the second floor. That's a basic thing of exercise. Thank you very
Thank
much,
you.
Anil, for the nice
Thank you.
speech. Over to Prasanna Kumar.